Hello students, welcome back, and in this video lecture we will talk about iron deficiency anemia, which is the most common nutritional deficiency in India, in our country. So coming to iron deficiency anemia, which is a microcytic hypochromic anemia, means the cell is going to be smaller, hemoglobin is going to be lesser, and this is a kind of anemia that means hemoglobin will also be less. So what are the other microcytic hypochromic anemia? You can remember with the mnemonic SITA, S for sideroblastic anemia, I for iron deficiency anemia, which is the most common nutritional deficiency in our country, T for thalassemia, and A is the anemia of chronic disease. And this either you can have normocytic normochromic anemia, which is a more common type. So it has got two different types of morphologies. Either it is going to be normocytic normochromic, or it is going to be microcytic hypochromic. Microcytic hypochromic. So coming to this topic, which is the iron deficiency anemia, most common nutritional deficiency in our country, from where iron absorption takes place, very important point, it is the duodenum from where the iron absorption takes place. The site of iron absorption in the body is duodenum. Which form of iron is absorbed? Which form of iron is present in the food? Both are different. So the iron form which is present in the food is Fe3 positive. It is not absorbed in Fe3 positive. So there is some other form of iron that is absorbed in the that is Fe2 plus. Fe2 plus is the form of iron that is absorbed. Fe3 plus is the form of iron that is present in the food. So both of them are different. So first of all, in the food we are taking Fe3 plus, and then it is converted to Fe2 plus, and then it is absorbed in the duodenum. These are the 3 points that we have already studied till now. That in the food we take as Fe3 plus, in the duodenum it goes converted to Fe2 plus, and then it is absorbed. So the food iron is of two types. It is going to be present in any of these. If it is heme iron, it is present in non-veg food. If it is non-heme iron, then it is formed in the veg. It is formed in the veg food. So you can see in either of it, non is going to be present. So if it is heme iron, it is non-veg food. If it is non-heme iron, it is a veg food. Then what decreases the absorption? What increases the absorption? You must have heard this saying that with milk, with tea, with coffee, we don't take iron. We take at least 30 minutes of gap between tea, coffee, milk, and all these things. And also, vitamin C tablets are given for the iron absorption. So acids, all the acid like hydrochloric acid in the stomach, HCl, it is an acid. Acid word, if you see, it is going to increase the absorption of the iron. And if you have seen that, you can take iron tablets with the juice, like the mosmi juice, right? So all the citrus fruit juice, or with the lemon water, you can take iron, but not with milk, not with tea, not with coffee. So basically, if it is acid, it is going to increase the absorption of the iron. If it is alkaline, it will decrease the absorption of the iron. So all the food that ends with acid are going to increase the absorption of the iron. For example, hydrochloric acid as amino acid, which ends with acid, ascorbic acid, which also ends with acid, which is vitamin C, it increases the absorption of the iron. While on the other hand, what decreases the absorption of the iron is milk, phytate, tannate, tea, and coffee. These decreases. So that is why iron tablets are not taken, or at least a 30-minute of gap is taken if you are taking milk, tea, coffee, anything with the iron. Now, as I told you that Fe3 plus form of iron is present in the food. It goes to the duodenum. It is absorbed in the duodenum as Fe2 plus form. And then this iron is actually transported to the bone marrow, because in the bone marrow we have RBCs, in the RBC we have heme, and iron is required for the heme synthesis, for hemoglobin synthesis. And we can say it is very important that this iron is reached to the bone marrow where these RBCs are synthesized. During this erythropoiesis process, we need this iron. So what is the transportation form of iron? The form of iron that is transported is known as transferrin. Remember, it is a ferry. Transferrin is the transportation ferry. If I say the word ferry, means it is the transportation form. Ferry, we know that. And what is the storage form? It is stored in tin container, and the form is ferry tin. So it is just a trick to remember that how it is stored in the tin container, you can remember, and how it is transported in the ferry. So transportation in the ferry, stored in the tin container. So transportation form of iron is transferrin, while on the other hand, storage form of iron is ferritin. So tin means storage form, tin containers, and ferry means transportation, that is transferrin. What is the transportation form of iron? It is transferrin. What is the storage form of iron? It is ferritin. Very easy to remember. Ferritin. Tin means storage form. Transferrin. Ferry means it is the transportation form. Ideally, this transferrin is going to take, it is a ferry, it is going to take the iron molecule. So it is kind of a ferry in which the iron molecules are sitting nicely. Now, imagine this is a transferrin molecule, and this is a transferrin molecule, and it has got, ideally speaking, one molecule of transferrin has got 6 molecules of, it binds to the 6 molecules of iron. It is ideally speaking, not practically speaking. It has got sitting arrangement for 6. Now, if this is a ferry, it has got sitting arrangement for 6 people, right? Now, it is so close that if one person come, person is going to sit here. Another person will not come and sit next to it. It is very congested. So the another person will keep a place and nicely stay apart. In the COVID times, we have seen that we don't stay close, we make distance. So the other person makes some distance and then sit on the other side. So ideally speaking, it has got valencies for 6. It can bind to the 6 molecules of iron, but practically speaking, 1 molecule of transferrin binds to only 2 molecules of iron. So this is the transferrin molecule, 1 molecule which binds only to the 2 molecules of Fe2+. So Fe2+ is actually the absorption. It is the transportation, which is Fe3+. So it is the 2 molecules of iron that binds. There are total capacity of 6, but now only 2 are occupied. So what is the total occupied percentage? It is only 33%. So normal transferrin saturation is only 33%. Normally, instead of sitting 6 iron molecules, only 2 are sitting, practically speaking. And that is why, what is the saturation? The saturation of the transferrin is only 33%. Now, this transferrin molecule, this is a transferrin molecule, though it has got 6 capacity binding for iron, but it is binding only, practically speaking, to the 2. So we have this molecule on which the transferrin binds to the iron, and then this molecule is transported to the bone marrow. This is the transportation form. That means transferrin is going to take up 2 iron molecules, and then this is a ferry and it goes to the bone marrow. So the erythroblast in the bone marrow, we have erythroblasts that are present in the bone marrow. Erythroblasts are the precursors of the RBCs. We know that erythroblasts are the cells that are going to form the RBCs, and blast word means we are talking about the bone marrow. This we have studied in the previous lecture, the precursors. So erythroblasts in the bone marrow are the one that makes the hemoglobin. Erythroblasts have got a lot of transferrin receptors, and the molecule bind here. If this is an erythroblast, we know that in the bone marrow nucleus is present, so they have got a nucleus also. This is a transferrin molecule, TF, which binds to 2 iron molecules, normally speaking or practically speaking. This is going to get transported to the bone marrow, to the erythroblast present in the bone marrow, and this erythroblast has got a receptor for the transferrin. So this is transferrin receptor that is present on the precursor of RBC, that is the erythroblast. So this erythroblast, which is a precursor of erythroid cell RBC in the bone marrow, it has got a receptor for transferrin. This is transferrin receptor, to which this whole of the molecule comes and attach, and then it is transported inside. Then this receptor is present on this erythroid precursor, and here this complete molecule is taken inside. This complete molecule, which is transferrin, as well as 2 iron molecules along with it, and then they are separated. Iron is separated and transferrin is separated here, and this molecule is known as endosome. Inside the endosome, now this iron and the transferrin dissociations take place. So basically what happens, the bonded transferrin and the iron molecule, it get transported to the bone marrow. Here in the bone marrow, we have the erythroblast. These are the precursors of the RBC that makes hemoglobin, right? So erythroblasts have got lots of transferrin receptors, and the molecule binds here. There is increase in the transferrin receptor that is present in the early erythroid precursor. Why? Because in the early stages, hemoglobin is produced. That is why we have studied what are the 3 erythroblast cell in the bone marrow. Early erythroblast, intermediate erythroblast and late erythroblast. So it is the early erythroblast that is going to have lots of transferrin receptor because it is going to make the hemoglobin. So late normoblast then release this transferrin receptor. If it is a late normoblast, it releases this transferrin receptor. This is the transferrin receptor, it releases it. Therefore, more transferrin, if there are more transferrin receptors, means more hemoglobin is synthesized. So these receptors are later on released in the blood, and therefore there is increase in the serum levels of transferrin receptor. If it is increased, that means it is a marker for erythropoiesis. That means more of the RBCs are forming, more of the hemoglobin is forming. If there is increase in the serum level of transferrin receptor. Why? Because in the late normoblast, in the late erythroblast, these receptors are released from the cell. See, we have erythroblast or normoblast, right? These are the normoblasts. These are the cells that are present. These are the RBC precursors that are present in the bone marrow. They are of three types: early, intermediate, and late. Early has got a lot of transferrin receptor. When the cell reaches to the late erythroid, then these receptors are released. That means if in the blood, if there are more transferrin receptors, that means there is going to be more of erythropoiesis. So it is a marker of erythropoiesis. What is a marker of erythropoiesis? Increase in the serum level of transferrin receptors is a marker of erythropoiesis. Then what is the site of absorption of iron? It is in the duodenum. Which form of iron is absorbed in the duodenum? It is Fe2+, while on the other hand, the iron that we take in the food is Fe3+. What are the components that increases the absorption? All the acidic component increases the absorption. All the alkaline component decreases the absorption. What is the transportation form of iron? It is the transportation form is the ferri. So it is transferrin. What is the storage form? It is in the tin container. You can remember that is ferritin. And what is the normal transferrin saturation? It is 33%. Though it has got a potential for marking for taking 6 iron along with it, but ideally 6 can go, but practically speaking only 2, it takes only 2 molecules, so the saturation is only 33%. What is the marker of erythropoiesis? Increase in the serum transferrin receptors level. That is a marker of the erythropoiesis. If transferrin receptors are more in the serum, that means more erythropoiesis is going on. Now talking about the absorption of the iron. There are 3 things. We know that iron absorption takes place in the duodenum. So this is a duodenum cell. Then this is the apical part and this is the basolateral part. Now when the food comes in the Fe3+. The form of iron that is present in the food is Fe3+. Then it is converted to Fe2+, and this Fe2+ form is then absorbed in the duodenum cell, right? So Fe3+ is converted to Fe2+. This conversion takes place with the help of cytochrome B reductase enzyme. This Fe2+ needs someone to take to the duodenum cell. Who is this someone? It is DMT1, divalent metal transporter 1. So DMT1 is the person who takes up Fe2+ from the apical part, takes to the duodenal cell, takes it inside. So the absorption of iron, absorption of Fe2+ inside the duodenal cell occurs with the help of DMT1. What is DMT1? It is divalent metal transporter. Divalent means all the metals that has got a valency of 2, it is going to transport those metals. So divalent metal transporter 1, divalent metal transporter 1 is going to take all the metals who have got valency of 2, such as it can take manganese, magnesium, copper, or the Fe2+. It is then easily absorbed into the duodenal cell now that we have Fe2+ in the duodenal cell. Who takes up this Fe2+? It is the DMT1 who takes up this. Now from here, this iron is taken up, Fe2+. We have a Fe2+. This is taken via the ferroportin. We have ferroportin here. This is some other person who takes up this Fe2+ into the blood vessel. Ferroportin is the one who takes up Fe2+ into the bloodstream. Now that we have Fe2+ in the bloodstream, we can take this Fe2+ to the bone marrow, because actually we need this iron into the bone marrow so that hemoglobin can be synthesized. So this Fe2+, this ferroportin, is some person who's going to take up this Fe2+, and taken to the blood vessel. Now this Fe2 plus is not only present in the duodenal cell. Duodenal cell has got ferroportin. Apart from that, ferroportin is also seen in placenta. It is also seen in macrophage of the bone marrow. If you remember previously, arthroblastic island, we have studied that inside macrophage provides iron to the arthroblastic islands, right? So in the previous lecture, if you can recall image, we have discussed that macrophage is the one who is going to give iron to the arthroblastic precursor. So it is also present in the macrophage of the bone marrow. So this ferroportin, it is going to port the iron. It will port the iron from the duodenal cell to the blood vessel. So whenever iron is required inside the body, ferroportin is the one that is going to give. So here transferrin binds with a molecule of Fe3 plus. Here we have this, first of all, this Fe2 plus gets converted back to Fe3 plus. Then it binds to the transferrin. It binds to the transferrin, and we know that 2 molecules of Fe3 plus binds to the transferrin, and this goes to the bone marrow. This goes to the bone marrow. This is what we have studied. So transferrin binds with the 2 molecules of Fe3 plus, 1 molecule of transferrin bind with 2 molecule of Fe3 plus. Though it has got a valency of 6, it can bind to 6 ideally speaking, but practically it takes only 2 iron and goes to the erythroblast to make hemoglobin. We know that erythroblasts have a nucleus and transferrin receptors are present near to the bone marrow. Transferrin binds to the iron and then it reaches to the bone marrow. And we have also discussed the bounded molecule, it gets engulfed, and this is known as endosome. Whole of these is engulfed and this is known as endosome. And here the iron and transferrin both get separated again. So iron gets separated, transferrin gets separated. This iron goes to the mitochondria. 90% of the iron goes to the mitochondria, only 10% goes to the cytoplasm. So majority of the iron that is used in production of hemoglobin, it goes to mitochondria, and 10% goes to cytoplasm. So this is basically the cycle. How this iron is transported, what is the absorption, how iron is absorbed. Who's the master regulator of the iron? The master regulator is the one we have not talked about. That is hepcidin. Hepcidin word is there. Remember IN and we have hep. Two things that you need to see. Hep and IN. IN means inhibitor. It is going to inhibit the absorption of the iron by inhibiting the ferroportin. Ferroportin is the one who's going to port the iron from duodenal cell to the blood vessel. If iron is not going to the blood vessel, it is not reaching to the bone marrow, right? So from duodenal cell, though iron is present in the food, but it is not reaching up to the bone marrow for the hemoglobin synthesis. And hepcidin, that is why we call it, he is a master regulator of the iron. Though it also inhibits the release of iron from the ferritin. So ferritin, which is the storage form, though storage form of iron is present, but it is not reaching to the, also from food iron is not reaching to the bone marrow because the port is inhibiting, and also from the release from storage is also not present. So money cannot be withdrawn from the ATM, and also the job is lost. So these are the two things. That is how he is the master regulator of the iron. Hepcidin, in means inhibits, it inhibits, and hep, you can remember the source as hepatic or liver. So hepcidin is the one who's the master regulator of the iron. What are the causes of iron deficiency anemia? We have already discussed. Most common nutritional deficiency in our country is iron deficiency anemia. Either in the diet iron is less, or the demand of iron is high. For example, in case of pregnancy or a child or lactation, all these things, there is increase in the demand of iron. In that case, also the person can go into iron deficiency anemia. Or in the diet, there is deficient, iron is deficient, either decrease in the diet or increase conditioned. Or if the iron is lost via the blood, for example, increase in the blood loss due to any parasitic infection such as a hookworm infection in children, or in adult in blood loss in peptic ulcer disease, or in old people in case of colon cancer, or a female with a heavy menstrual bleeding, blood loss causes loss of iron from the body. The site of iron absorption is present in the duodenum, and that is why if there is any disease present in the duodenum or intestinal, that can also cause decrease in the iron absorption. For example, celiac disease, it has got a lot of D's like diarrhea, deficiency causes anemia and duodenum effect. What are the 3 stages of iron deficiency anemia? First of all, when the iron is not there in the diet, then body takes up iron from all the stored form. What is the stored form of iron? It is ferritin. Remember tin. first, the iron is first taken up from the stored form. If you are not taking iron in the diet, the blood RBCs required iron. But if you're not taking iron in the diet, then it is taking up from the storage, right? So ferritin, first of all, there is decrease in the storage, decrease in the ferritin. Then the ferritin also gets depleted. Now there is no storage form in the diet, also no iron is coming, and therefore the RBCs goes into the iron deficiencies. Therefore there is going to be deranged iron profile. We'll talk about all the tests in a while. And the third stage is the cells are going to be microcytic, smaller in size, hypochromic, less color. So what is the clinical presentation? The person will have fatigue. All the females with iron deficiency anemia, they cannot work out properly, they cannot climb stairs properly, they cannot do a lot of physical exercise because they get tired so easily. So fatigue is something that is associated with iron deficiency anemia. Also koilonychia. Koilonychia is the one that is spoon-shaped nails. So spoon-shaped nails is the one. Normally what we see, nails are like this, right? Nails are like this. But here the nails become spoon-shaped. So you can see, make out, this is koilonychia. Also angular cheilitis. There is rupturing or dryness at the angles of the mouth. In the children who have pica syndrome, pica is the one, if you have seen mothers complaining that my child eats mud or sand in the park, or the child eats chalk at the school. So basically pica syndrome is the one in which the child eats non-edible items such as chalk or mud. This is the pica syndrome. The children with the pica syndrome, they also have iron deficiency anemia. Plummer-Wilson syndrome, a middle-aged female representing with dysphagia, difficulty in eating, has got iron deficiency anemia, which is sideropenic dysphagia, which is known as Patterson-Kelly-Brown syndrome. What is this? Plummer-Wilson syndrome, which is also known as Patterson-Kelly-Brown syndrome. This is sideropenic dysphagia. Sideropenic. Sidro word means iron. Penic means deficiency. So this person will have iron deficiency anemia. Also, there is dysphagia component. That means there is going to be difficulty in eating. So it is a triad of three things. That is esophageal webs. In the esophagus, webs are formed. Iron deficiency anemia and atrophic glossitis. Atrophic glossitis. So this is Plummer-Wilson syndrome or Patterson-Kelly-Brown syndrome. In the blood with the iron deficiency anemia, you will find less hemoglobin. You will also find low MCV. That means the person will have microcytic anemia. Low MCH person will have hypochromic anemia. There is going to be low MCHC, but there is going to be high RDW, that is red cell distribution width. So red cell distribution width is going to be high. That means there is going to be variation in the sizes. There is going to be a small size RBC, a big size RBC, a normal size RBC. So there is going to be a variation in the sizes of the RBC. And what do we call it? We call it anisocytosis. Anisocytosis. Why this anisocytosis is seen? If a person was having iron deficiency anemia, next day the person takes up iron-rich food, spinach, he takes a lot of spinach or she takes a lot of spinach. So in that case, there will be normal cell. Some of the cells are going to be small, some will be normal. So that is why there is going to be a variation in the sizes of the RBC, because there is a nutritional problem. It is associated with deficiency of iron. All the parameters will be less except the RDW, that is red cell distribution width, is going to be increased. If you see microscopically, what you find is, first of all, compare it with a lymphocyte. This we have studied in the previous lecture, that compare it with a lymphocyte. If you see a lymphocyte, look at the nucleus of the lymphocyte and compare all the RBCs with this lymphocyte. This is a normal RBC. This is a normal RBC, which has got 1/3 of the pallor. But here you can see these are the RBC centrally, which has got more than 1/3 of the pallor. And if it is more than 1/3, we call it hypochromic. That means less color is present. If you can see, there are also smaller size of RBC compared to the nucleus of a lymphocyte. Smaller size RBC. That means it is also microcytic. Microcytic, hypochromic. Microcytic means smaller size. Hypochromic means less of the color is present. Few cells are big, few cells are small. There is a variation. and this variation is known as anisocytosis. Also, what you find in the size, there is a variation. Along with that, you can see that there is a variation in the shape also. So you can see a pencil cell, variation in the shape, SHAPE, variation in the shape. Take shape. What is the variation? It is pencil cell. Another take P. So what is it known as? It is known as poikilocytosis. Poikilocytosis is when there is a variation in the shape of the RBC. When there is variation in the size of the RBC, what is this called as? This is called as anisocytosis. If there is a variation in the shape, P shape, it is known as poikilocytosis, pencil shape. Sometimes, RBCs hardly have any hemoglobin. You can see there are empty looking RBCs. Just a ring is present. You can see only just a ring is present. You can see these RBCs. So they appear like a ring because there is a severely deficient hemoglobin, and this is known as leptocyte or pessary cell. Retic count is increases. You know why this count increases? Because the person is having anemia and bone marrow is trying to work hard to make the reticulocyte. Bone marrow is trying to make new reticulocytes, more reticulocyte. But since iron is not present, how much bone marrow will make? Because iron is not present, hemoglobin is not formed. So bone marrow is trying to work hard. That is why there is increase in the retic count. There are more reticulocytes, but they are not able to catch up. So the proportion of the degree to which the anemia is present, to that proportion reticulocytes are not synthesized. What are the iron studies? There is going to be decrease in the serum iron in the blood. Iron is low. Transferrin saturation is also less. And also there is low ferritin. The storage, because first of all, when in the diet iron is not present, in the serum, when in the diet iron is not present, first of all, storage forms start getting empty. So that is why the storage form is also less. Then transferrin, the saturation, transferrin, it takes up 2 molecules. That also saturation is decreased in iron deficiency anemia. But there is increase in the total iron binding capacity because there is a lot of hunger. The RBCs are hungry of iron. So whenever they get iron, they are going to grab it on the spot. So there is increase in the total iron binding capacity because the hunger is increased. Now what happens? This iron gets combined with the protoporphyrin. Iron gets combined with the protoporphyrin and then hemoglobin is formed. If iron is less, hemoglobin is less, then it is going to cause lots of protoporphyrin free in the blood. So that is why the free erythrocyte protoporphyrin is increased. So 2 things are increased. One is total iron binding capacity. Another one is free erythrocyte protoporphyrin. So this iron combines with the protoporphyrin to make hemoglobin. Iron is less, hemoglobin is less. That is why the protoporphyrin are free in the blood. So that is why the free protoporphyrin counts increases. What is the normal serum iron level? It is 50 to 150 microgram per deciliter. You can remember average of 100. And total iron binding capacity, just calculate it with multiplied with 3. So what is 100 into 3? It becomes average of 300 microgram per deciliter. Transferrin saturation is normally 15 to 50%. We have studied that it is almost around 33%. Now, bone marrow studies. Iron deficiency anemia can be detected without a bone marrow testing, right? We don't need bone marrow testing because bone marrow testing is invasive procedure. You take a needle, stick into the bone marrow, and it is a painful procedure. You don't need for iron deficiency anemia. Regular RBC precursors normally are normoblast. But in iron deficiency anemia, the matured cells, that mature RBC will be microcytic. We know that microcytic hypochromic. This is a peripheral smear looks like for iron deficiency anemia. But if you see in the bone marrow, the precursor are also small. That is why we say micronomoblasts are seen in the bone marrow. If you take the bone marrow study for iron deficiency anemia, the normoblasts are also smaller in size. Matured cells though are smaller in size. They are microcytic hypochromic. But the normoblast, the erythroblast are also smaller in size. Now, if you stain this iron, that is the pearl stain or Prussian blue stain, in this you get 0 grade iron because there are no iron stores that are present. That is why 0 grade iron. So the bone marrow is going to be a gold standard, and you can, if you take Prussian blue stain and you check actually how much iron is present, and what you find is no iron in the store. So that is a gold standard and most specific test for actually testing iron deficiency anemia. Coming to the treatment part, we give iron supplements. if there is underlying cause that is causing iron deficiency anemia, suppose if the blood loss is causing iron deficiency anemia, or if it is deficient in the diet, then you can also add iron supplements in the diet. So basically we give iron supplementation for iron deficiency anemia. After blood testing, after you do the diagnosis, we give patients with the iron supplements. We ask the patient to come after 7 days or 1 week, and then we find out the reticulocyte count in the patient. And what we found out, there are more the reticulocyte count increases. That means the bone marrow is responding properly. So this is the treatment of the iron deficiency anemia majorly, which we give the iron supplementation. So this is about iron deficiency anemia. All the best.